Um, so I have the pleasure of introducing our guest speaker, Dr. Jeff Kline. He is an emergency physician and the Eskenazi Foundation Professor and Vice Chair for Research at the University of Indiana. He is also the Editor-in-Chief of Academic Emergency Medicine, really one of our major specialty journals. And most of us, I think, who are emergency physicians think of him as, the authority on all things pulmonary embolism. For those that don't know his work, he was the leading drive behind the development of the PERC rule. So please lean in on this one and welcome Dr. Kline. Actually, one statement I want to make before we get started. So we are going to have time for questions. We're going to reserve those until the end. So put those into the Q&A box, and we will collate those in the background and circle back to those at the end of the talk. All right, take it away, Jeff.
All right, thank you, Keith. It's my pleasure to be here and get to talk to the collaborative. So here are my disclosures. I'll point to the first disclosure because I am going to talk about some research that I've done that was funded by Janssen and Pfizer. You can see the rest of my disclosures here. What I'd like to do is I would like to go from relatively dogmatic down to just sort of pure research. I'm a researcher, so if you ask me to talk, you're going to get some of my research that I'm involved in. But what I hope to do is to talk about some pragmatic issues that probably most everyone knows about, but just to maybe update on where we are with clinical practice guidelines and really talking about what is now reasonable and prudent to say is medicine. It is 1A and ready to use, and then go down to some more speculative and what I would call fun thinking that hopefully will generate some discussion. So let me just start with an overview of a typical management algorithm when it comes to diagnosis and exclusion of pulmonary embolism. And typically most of these will start with some type of pretest probability or sort of out of the primordial soup of our decision making, a way of organizing the probability of pulmonary embolism. And I think there are lots of validated ways. I'll re-emphasize again and again that Gestalt, just asking the question, do I think it's low pretest probability is as good as, maybe better than a Wells or simplified revised Geneva score. That simplified revised Geneva score always raises a little confusion because there was the Geneva score, then there was the revised one, and then there was the simplified revised one. And I'll give a little pointer. The Wells score and the simplified revised Geneva score basically are scored the same way when it comes to ordering D-dimer. If either are below 5, then you're good for a D-dimer. If they're in the low probability zone where you ask yourself the question, do I think PE is unlikely? Do I think this patient does not have PE? You're good to use the PERC rule and then move through a quantitative D-dimer. I'm going to strongly emphasize that age adjusting is ready for prime time. And then over here is the imaging side, which is, I see, an important part of the collaborative. And I'll talk a little bit about imaging, but mostly just about getting started. And here's a reminder of what the PERC rule is. It asks the doctor or advanced practitioner to say, do I have a low Gestalt suspicion? And that's just requires you to get your own attention and think about the patient in the patient's entirety, and then make sure they have these 8 criteria. And if they're all negative, then this reliably predicts a probability of pulmonary embolism that's less than 2%. And that's with 45-day outcome, which is similar to what you find with a negative CT scan or a negative D-dimer. And there was a controversy that existed for about the last decade that it worked well in US populations, but there were questions raised about whether or not this would even work in Europe because they have such a higher prevalence of disease. So that set up the need for a European management study where PERC rule was used or not used. And Jonathan Freund did it in this thing he called the proper study in France, where France, they typically will have prevalences of PE on their CT scans of 20 to 25%, even as high as 30%. And that's all. The Medic-wide collaborative has a prevalence of around 9%, which I'll hold out as extraordinarily high in the United States. But because of that concern, people weren't sure whether or not PERC rule would work in Europe. So with this management study, Jonathan randomized hospitals to either use the PERC or not, and he did so in a scientifically rigorous fashion where he made efforts to be sure they weren't already using PERC when they were using the wild type method. He enrolled 1,900 patients, and everybody in this study had to have a Gestalt low pretest probability using French Gestalt, which turns out French Gestalt works as well as American Gestalt because the PE rate in the whole population was under 3%, which is what we found reliably in the United States when we asked you, do you think this patient has a low pretest probability? That population will have an outcome rate of around 3%. So it worked well in terms of just asking Gestalt. That's an important finding from this JAMA paper. And what they found in the PERC group was only a 0.1 or one single patient had a false negative PE, and that person had a subsegmental PE that did ultimately get treated, raising the controversy of whether or not subsegmentals need to get treated. In the non-PERC group, there were lots more subsegmentals that ended up getting anticoagulation. And CTPA was significantly reduced with PERC by an absolute number of 8%, which was pretty good. So overall, that led to an adoption by the latest clinical practice guidelines that I know of. If there are others, I've missed them. Maybe NICE has some out. I know ATS does not yet, but is planning. And these were the American Society of Hematology clinical practice guidelines, which actually did not cover pretest probability scoring criteria, but recommended PERC nonetheless. And there's some of the exact language. American College of Physicians recommended PERC as a best practice advice, and ACEP gave it a level 2B several years ago, and I believe there are new PE practice guidelines coming out from ACEP soon. PERC was a choose widely recommendation. So just a reminder, this is a reasonable and prudent thing to do. In terms of my own research, I'm turning to PERC in children and have a large project through PCARN where we're testing something we call PERC Peds, which will be the same except we'll have a age-adjusted heart rate. So that's upcoming. So I think this is some relevance to the collaborative, and that's the long-known fact that young women are over-tested, but yet are at the biggest risk for low-value CT scanning, primarily because of the risk of breast cancer. There's really no reason that women should be getting tested more. They have the same rate of PE, but in the emergency department, they comprise up to two-thirds of patients receiving CTPA, and typically a higher number who receive low-value CTs, meaning those with very low outcome probabilities, like in the 2 to 3% range. And this is something that I think that this raises controversy because a lot of emergency physicians don't want to think about it. But these are 6 fairly large registries done in 6 different countries that basically tell us that for every 10,000 CTPA scans performed on women less than 40, about 35 as a direct result of that single CT scan are going to develop cancer in one of these organs. So whether you choose to believe this or whether you don't, this evidence is out there, and it could come back to haunt us as population scientists look more at low-value CT scanning, particularly in women. Along those lines, we did some work in 26 hospitals, including in the Indiana area and in the Indiana state using the IU Health system, and also the Baylor Scott and White system down in Dallas. And what the main question was about whether there was a difference in these two systems. Now, the Baylor Scott and White system had implemented a specific quality improvement program similar to what the collaborative has done. And that's to go in and teach emergency physicians to use the PERC rule and D-dimer liberally or more efficiently. And then did follow-up to show each doctor how each doctor was doing relative to their peers. Those are the blue squares, and then the black circles are Indiana, my own health system, that did not do any such teaching. So we had 27 hospitals in this. And the point of this regression analysis is each dot is a hospital. And the more D-dimer use, the higher the PE yield rate. Now, this is just correlation, it's not proof. One thing I thought about was I wrote this paper and it published in January. Boy, I didn't expect what the byline of this title would mean coming up, the continuing epidemic. I don't know if that was prescient or not, but man, we've had an epidemic. So that raises the question, people, they kind of resist using the D-dimer. They know there's a high false positive rate for all the reasons shown over here in these bullets. One that really particularly vexes emergency physicians is pregnancy, and this scatter plot shows D-dimer concentrations as we move forward in later pregnancy out in the third trimester. Almost all the dots are above the threshold for an abnormal D-dimer, shown in that dotted horizontal line down there. So some kind of an adjustment is necessary if you're even going to try to use a D-dimer in the third trimester of pregnancy, for example. And you can see a similar plot, it might be in reverse post-operatively or in patients with cancer undergoing treatment. Most of the dimers are above threshold. Age naturally increases the D-dimer. It's unfair, but there's more inflammation and our bodies fall apart. And the immune system is connected to the coagulation system. And as we get older, we have more reactivity and higher D-dimers. That led to the biological basis for age adjusting the D-dimer. And simply stated, age times 10 for patients over 50, that's a reasonable standard of care. It's received a strong recommendation, a level 1A from the ASH guidelines. And I just want to hold this out again that if you're not doing age adjustment and not promulgating it, well, you probably should be giving a good explanation of why not, because it is a level 1A and it is ready for prime time. And this is just some data from the ASH guidelines showing the overall performance of the D-dimer. For example, just look at the top part of the red box, sensitivity 97, specificity 39. If we age adjust, the sensitivity stays the same, essentially. It certainly doesn't increase. I would just say those are within confidence intervals. And we got an almost 10% increase in specificity. So that's the benefit and should be used. Now, there are other threshold adjustments, and I want to talk for a minute about pregnancy because this is a question that comes up in virtually any PE talk. And we now have 2 management studies that tell us that we can use the D-dimer in pregnancy. In a clinical practice guideline published about 8 or 10 years ago by the American Thoracic Society, they actually cited that they didn't think the D-dimer was warranted or didn't believe that it was safe. And now we have evidence that, in fact, it is. There are different ways to cut the threshold off, but probably the simplest is just to double the standard threshold for the D-dimer. I could spend some time talking about thresholds in D-dimer and FEUs and D-dimer units, but maybe I'll wait and see if we have questions on that. That's always another problem, but not the focus of my talk. But assuming we're using the standard cutoff, it's safe to double the threshold in patients that are pregnant that have a low pretest probability. And that is really given to us by the years protocol. But adoption of D-dimer is slow because the doctors perceive it as a waste of time. And we know that only fewer than a quarter of active practicing emergency physicians really even know about age adjustment of the D-dimer, and even fewer than that use it. We've only seen modest effects on computerized decision support, and doctors will often game the system to order a CT. And they don't really do a good job of determining, when we do research, about doctors' decision-making and their underlying desire to find pneumonia on CT scans, since pneumonia is more common than PE in most samples. Maybe not MEDIC, but in most samples. And this sort of has led to my tongue-in-cheek way of thinking about D-dimer, and this is a joke. This is a joke. I used to tweet a lot, but then just kind of decided that it was kind of a waste of time. But anyway, I tweeted this silly thing talking about the way doctors really think when it comes to D-dimer, and I think it got retweeted about 5,000 times because people thought it was funny. But ultimately, it just ends up in ordering a CT scan no matter what, and then going home and drinking. So it can be frustrating for many physicians. Oh yeah, this is the slide about the confusion and the threshold, and just want to point out the 35 D-dimers have been cleared by FDA, and the FDA just asks about whether or not they do what they say they're going to do. They don't compare different assays, and as a result, I mean, in terms of their threshold, they're not required to do any type of standardization. And this goes back to the fact that the D-dimer is a post-translational modification of fibrinogen that, of course, has been linked by factor 13, then cleaved by plasmin. And it's actually impossible to make a D-dimer recombinant molecule as a standard to be able to set thresholds. Therefore, D-dimer assays have different antibodies with different epitope affinities, and we have all of these different thresholds. And then we got FEUs versus DDUs. FEUs is the typical 500 number, whereas DDUs are usually half that. That's the D-dimer unit. If you ever get mixed up about this, or you're trying to teach learners about FEU versus DDU, the way I try to tell people is the word fibrinogen is bigger than the word dimer, and the fibrinogen equivalent units are bigger than the D-dimer equivalent units. So there, I've taught you something that's incredibly useful. All right, interim summary, the PERC rule is safe and effective and is really now a new standard of care, pretty much receiving 1A type guidelines. And increased D-dimer use can decrease low-value CT scanning, an imperative to this collaborative. And physicians dislike the D-dimer because they perceive it as low specificity, but we can help address that with age and pretest probability adjustments to the net exclusion rate, and that's a new standard of care, even in pregnancy. And the problem of solving different assays thresholds, that continues to be a problem, and is one that's not going to be readily solved, and is one that I've myself tried to engage the FDA to help, and the American Association of Clinical Chemists, and I've done presentations there, but really this is up to industry, and I don't think that they're going to fix their thresholds because it would cost them money. Yeah, let's spend a second about pregnancy here, and this is a typical pregnant patient in the second trimester. It is said that the risk of PE increases with each trimester of pregnancy. There's a lot of things that are said about PE in pregnancy that really are not backed up by evidence. And this is just a reminder that we are really afraid of PE in the emergency department. This is a systematic review, meta-analysis that we did of the literature, looking at the prevalence of PE among pregnant patients tested for PE in the emergency department. And what we found was, in combining all of these studies, and these included studies in Europe, that the prevalence of PE in pregnant patients was 3%, which was actually lower than in the overall population. And this doesn't necessarily say anything about the risk of PE, but it says that our tolerance of that risk is extremely low. We order testing at an extremely low threshold for pregnant women, and a lot of them end up with a CT scan of the chest and that concomitant risk of breast cancer. Here's something you might want to try just for fun, again, for your learners, is just try MD Calc and look up the years criteria, for example, and put in pregnant patient versus not pregnant patient, see if it changes the outcome. And it doesn't, because it shouldn't. Pregnancy can be excluded using the years criteria, which was, of course, invented by Menno Huisman. It's just a modification of the Wells criteria. It's asking you don't think the patient has DVT, no hemoptysis, and you think PE is unlikely, then it's safe to call them low risk, even if they're pregnant, and use D-dimer. There used to be 0 management studies, but now we had 2 that allow us to go ahead and use D-dimer. And then here is the years criteria that I was talking about before, where if you suspect pulmonary embolism and they don't have any of those criteria that I just mentioned, you can use the D-dimer at the double threshold. And that allows a reduction in the use of radiation imaging. If you need to move forward and do radiation-based imaging of the pulmonary vasculature, I'll just give you the latest systematic review. There's several that are out comparing VQ scan versus CT scanning. And the bottom line is that they are pretty much equal. The technique can matter. I think a lot of people don't realize that the indeterminate rate for CTPA in pregnancy is higher than it is in non-pregnant patients because of shielding and crowding of the lungs and higher respiratory rates. But either one is adequate. I personally prefer doing a chest x-ray if it's negative, if it's clear, moving on to half-dose perfusion lung scanning. And if just for no other reason, we've been using scintillation lung scanning in women that are pregnant for 50 years, and there's just not a lot of negative literature on that. We're not seeing an increase in miscarriages or any teratogenicity that's known or cancer. The CTPA is less well known, and I'll remind you that the contrast crosses the placenta, it goes into the amniotic fluid, the baby swallows it, and there are thyroid effects that we really don't know that much about. So the bottom line with pregnancy is you can exclude PE with low pretest prob and diameter twice the threshold. It's a new standard of care. And there's no evidence to say CT or VQ is superior. Use either one, and I'll just say VQ's been around longer. I use half-dose perfusion only when the chest x-ray is normal. It's your choice. Now I want to turn more to treatment of pulmonary embolism and some new standards of care that are out, and to talk about how this is another quality measure and probably one that will become more and more important. Now I put a little reference in here. This is a study by Mark Kovacs, and you see Phil Wells is on there, published in 2000, talking about outpatient treatment of pulmonary embolism. I remember in the late 90s, Phil Wells was presented a poster at ISTH, International Society of Thrombosis Hemostasis, and he was just talking about, yeah, these are the patients we treated as an outpatient for PE, and this was after the Columbus study had sort of taught us that it was okay to send DVT home. I remember saying to Phil, hey, are you going to publish this? And he sort of looks at me, and Phil is very tall. He's about a foot taller than I am, so he's looking down at me, and he says, he sort of shrugs his shoulder and goes, who cares? This is just what you should do. Well, it's probably that simple up in Ottawa, where they have a pretty established system of doing things, but it still has not been adopted in the United States. And we do have the American College of Chest Physicians and the European Society of Cardiology recommending outpatient treatments in PE patients with low risk of hemodynamic decompensation. And it's moving toward a best practice, but man, doctors don't do it. There is a need to risk stratify, and there's a bunch of different ways you could do it, but the two that are most studied and that there is more literature coming out, including literature that is in review with a large randomized design comparing SPEZI to Hestia. I'll tell you, they're equivalent. You can use either one. SPEZI is more of a structured criteria, and this is a checklist, and it requires 6 items. There's a couple of criticisms to this, but the biggest one is that it doesn't include your gestalt, which you need. You have got to have physician judgment to decide whether to send someone who satisfies this criteria home. For example, if they're psychotic or can't understand or adhere or take their medicine, they have no place to go. There's also nothing in here about bleed risk, which is something else we have to consider. So whenever using SPEZI, there is always clinical judgment plus these 6 criteria. Some people would argue that you wouldn't want to send a patient home with a SAT of 90% because their bounce back rate is very high. But SPESI is well validated and easy to use. And here's the Hestia criteria. I've modified it, and I gave a reference here to make the need for oxygen and need for IV narcotics greater than 24 hours a little more explicit, because it's hard for me to guess who is going to need doses of narcotics for more than 24 hours or need oxygen for more than 24 hours. The bolded bullet points, that would be the way the original Hestia was worded. And what I have presented here is my version of making it more explicit and simpler to use in the emergency department. But you know what the biggest component of Hestia that matters in an ER? And it's this third from the bottom bullet, other medical or social reasons to admit. And that flunks or fails out about 30% of patients who have Hestia applied to them for reasons that all of you know working in the emergency department. They've been compared head to head by Jimenez in a paper published in Academic Emergency Medicine. And basically he's found that they are equally good at predicting 30-day mortality, but a little higher kappa for SPESI. Well, of course there's a higher kappa because it doesn't have the subjective component, but if you add the subjective component, these two are fairly equal. And here's the RCT being done by Pierre-Marie Waugh, which I happen to know for sure is submitted for review. And this randomized trial head-to-head compared SPESI and Hestia, and I won't give a spoiler alert because that paper has not yet been unembargoed, but suffice to say things aren't going to change. The question that comes up about outpatient treatment of PE of patients who are SPESI negative or Hestia negative is, what if you have a positive troponin? Well, the answer is you very seldom have a slam out positive troponin. Usually it's borderline. If it's really positive, you need to be thinking about possible other myocardial injury like acute coronary syndrome, because a positive troponin definitely increases the mortality risk, as shown by this meta-analysis by Stavros Konstantinidis in the European Heart Journal last year. You clearly have an increase. Here's what I suggest. If you are doing an outpatient program and the patient is SPESI or Hestia negative, and you got a positive trope, at least put them in obs for 23 hours and trend their troponins. I think it's unwise to send them home if they have a slam out positive troponin. Because we're talking about a practical group of folks and drug access and adherence is important, I just want to point out that this can be a problem, especially for Medicare patients that are in the donut hole. But in the emergency department setting, whether you prescribe rivaroxaban or apixaban, which are really the only two drugs that you can use in monotherapy without injections, they're always free. And all you have to do is Google patient 30-day card or free access. You can Google anything for apixaban or rivaroxaban, and you can get this card. And literally, the patient can put it on their phone and take the prescription to the pharmacist and get 30 days worth of drug, full dose anticoagulation for free. And it doesn't matter their insurance status, and it doesn't matter whether or not they have Medicare or Medicaid. But for me as an ER doc, sometimes that's a stopgap measure while we're trying to figure out things like getting them qualified for a foundation, or maybe just getting them followed up with primary care or a clinic and let them deal with it, sort of kicking the can down the road when you're getting killed in the ED. But you can always get free card for the patient to get their medicine. So how does this really work? You know, I want to present you some new data. This is the methods paper, the protocol paper has been accepted at BMJ Open, but these are unpublished data that come from my group. I call this group the MATH VTE group, monotherapy anticoagulation to expedite home treatment of VTE. And this was an implementation trial that we did at 33 sites across the United States, and we just wrapped it up right pre-COVID. We had our last patient in and did data lock. And the way we did this was bundled DVT and PE together and treated them with DOACs, either Riva or apixaban, and risk stratified everyone the same, with the idea that DVT could be PE. At least a third of patients with DVT have silent PE, and unless you image, you don't know which third. And DVT can convert to PE in any instant. Also, it's not like we're already sending DVT home. I mean, doctors talk about it, but fewer than 25% of eligible patients with DVT are treated at home. So there's still a lot of room to go with DVT and way more room to go with PE. So we just bundle it and say VTE, the whole thing. Well, we enrolled 1,421 patients, including 518 at 33 sites. The primary outcome was the frequency of new or recurrent VTE within 30 days. And that happened in only 14 out of 1,421, a little less than 1%, with 95% confidence intervals below 2%. And bleeding, and this was this definition of bleeding was any patient who returned to the emergency department and was admitted with an instance of bleeding. This is not an ISTH severe bleed. In fact, only 1 of 12 patients received packed red blood cells. None received surgery. None died. None had an intracranial hemorrhage. Most of these people had some type of gastrointestinal evidence of hemorrhage and were anticoagulated and got admitted because no one wanted to send them home. Top limit of that confidence interval is 1.5%. So this is evidence of efficacy and safety. There was one signal that's very concerning in this implementation trial, and that was a very high non-adherence rate at 30 days. 8% of patients either self-discontinued or never started or never filled their prescription, and those patients were at the highest risk of these 14 cases for having VTE recurrence within 30 days. And then we did some interviews with the patients to ask them why they didn't adhere. And the most common reason was economic. And that could have been solved had the doctors, had the staff done a good job of letting the patient know about the 30-day free card. And apparently the patients didn't know it. So about half of the non-adherence was the patients said they had financial problems getting the medicine. So in summary, outpatient treatment for DVT and PE is now standard of care in an emergency setting. It's got clinical practice guideline endorsement. I'm providing you with new evidence, and there's more coming down the pipe. You can use either Hestia or Espezi plus clinical judgment. And you know what I like to say to kind of ease things off? This is from Jeffrey Weitz. He's another Canadian, been in the PE business for a long time. And what he likes to say is if they can walk in with their PE, they can walk out with their PE. And there is some truth to that. This is something that I would like to see the collaborative interested in looking at. Now I'm going to wrap up here in the last few minutes by talking a little bit about some what I would call research and perhaps a little bit more provocative and controversial components of this talk. And this gets into the research zone. And when it comes to research, mentoring is very important to me. And this is one of my mentees, Lauren Stewart. And, you know, a strong woman in medicine and a strong woman in research. We need more of that. And so I'll put her picture here. And her area of growing expertise is the role of metabolic syndrome in patients with venous thromboembolism in the emergency department. And what I'm going to come out is say something that I think you don't do right now. And I bet you'll do a little double take, but this is what I think, is if the patient is not already taking a statin, and you diagnose PE or DVT, you should order a lipid panel. Now stop there for a minute because you're probably thinking, well, that's not my job. That's a primary care physician's job. I don't order lipid panels in the emergency department, but I think you should because it's a patient-centered issue. And here's why, that is that about half of patients over 40 with VTE are going to have an LDL that's greater than 190, which is a 1A indication for statins anyway, just for cardiovascular risk reduction. You don't have to have them fasting. Doesn't matter if they just ate. The LDL is insensitive to that. It's the triglyceride part that they have to fast for, and I don't care about that. All I care about is this LDL. And if it's above 190 and they have PE or DVT, and you want to benefit the patient, get them on statins if at all possible. Look at this odds ratio for the risk of VTE recurrence. This is a paper Lawrence published. This is using the massive IMPC database with 125,000 patients in this study. And out of all of the risks for recurrent VTE, hyperlipidemia was the strongest, with the other metabolic syndrome components being stronger than even a history of cancer down here. Metabolic syndrome really increases risk, especially hyperlipidemia. I think it's reasonable to say order a lipid panel on all patients with PE and DVT. Is it standard of care yet? No. I'd like to see it get there. And this is just some visual proof of the metabolic syndrome effect on VTE recurrence in this is that large number of 75,000 patients with VTE. The previous odds ratio was 125 because it included DVT and PE. And this, look at the red lines compared to the black lines, and these are the presence of each of these components of metabolic syndrome compared to those that did not have the component. And why use statins? Well, there's now a meta-analysis out of 36 studies looking at VTE recurrence. Most of these are secondary analyses of other RCTs that had another primary endpoint. But it's pretty clear that the relative risk is lower if a patient's on a statin. And it's actually, the effect seems to be strongest in DVT and for the rosuvastatin version of the statins, which is the most commonly prescribed out there. And here's some propensity matching that Lauren did that's just now out in the American Journal of Medicine, talking about the strength of statin use as a preventer for recurrence risk. And if you can get them on a statin, it is a safety measure. And one of the worst things for quality of life and cost and just everything for a patient with VTE is a recurrence. Recurrence of VTE severely degrades perception of wellness and quality of life. And a statin can help prevent that degradation in quality of life. And just a reminder, this is a 1A recommendation, and I'm just showing something from the American College of Cardiology, that if patients have an LDL greater than 190, they should be on a statin. And that has nothing to do with VTE, or maybe something to do, but that's all just about cardiovascular risk reduction in general, with tons and tons of randomized trials backing that. Now, I mentioned VTE recurrence because I want to wrap up with a topic that's extremely important to me, probably to you, and you might not even know it, and to patients with venous thromboembolism for sure. And that's this thing that I call thromboneurosis. And I don't call it that in a pejorative way. It needs to be an ICD-9 diagnosis. Thromboneurosis is the consequence of being told you have a blood clot and really not having any good explanation for it, and knowing about the risk of recurrence, and hearing what doctors and nurses and family members and grandma and the TV tells you about your risk after you've had a blood clot. Even if it's a calf vein thrombosis, patients can get this. These are some data from a person named Hojan out of Denmark. And because they can follow all of their patients linked to basically an NPI type number, they can find out their long-term outcomes after diagnosis of venous thromboembolism. And what these plots show here on the y-axis is the risk of being prescribed a antipsychotic or psychotropic drug or sedative hypnotic after diagnosis of venous thromboembolism, the dotted line being cases, those that had VTE, and the straight line being propensity matched controls. Patients with VTE end up getting diagnosed with anxiety and depression and end up on medication much higher than the cases that are equally sick. And this is just a risk plot over on the right of being prescribed a drug compared to not. So it's just this replotted another way, the left-hand plot plotted another way. So some background data that talk about thromboneurosis. And these are some novel data that are unpublished right now and being done by Jacqueline Hernandez, another one of my mentees in the area, a Latina researcher who is interested in understanding the root cause of thromboneurosis, the psychological mechanisms, and what we can do as emergency physicians to help block this. There's now about 6 papers that have done focus groups of patients with VTE, recognizing focus groups as a biased sample, but 100% have some evidence of post-traumatic stress disorder. And ongoing focus groups, and this work being done by Jacqueline, shows that we make things worse. And here's some large population data, 72,935 patients with PE. And I just want to show you something for inference. And that is the percentage of patients who had one of these diagnoses made after PE was diagnosed. Cancer, that was only 18% this is way over a 5-year follow-up, had cancer diagnosed after PE. This is always a concern. If you have an idiopathic PE, am I going to miss a cancer that's hiding somewhere? And lots of evidence that that's not really the case, although 18% did develop cancer. Many more develop these other diseases. It's not surprising that you'll see a higher rate of GI bleed after diagnosis of PE because people were put on anticoagulants, so GI bleed increased. But look at the most common 2 diagnoses that occur after PE diagnosis: depression and anxiety. Over half of patients with PE get diagnosed with anxiety or depression. And you know what? We make it worse. And I want to show you some transcripts off of in vivo from the work that Jacqueline is doing. And these are the words that the patients heard and remembered. And these patients were interviewed between 6 and 23 months after their diagnosis. So they remembered these words and carry them around and to some extent are haunted by them. But these are words to not use. They remember somebody saying, usually somebody in your situation would be on a respirator and can barely breathe on his own. Another one, I was so dangerous. Patients see themselves as bombs about ready to blow up. I was so dangerous 10 minutes ago that I wasn't allowed to walk to the restroom by myself, but now I'm healthy enough that I can go home. This sentence has several connotations. One is telling patients how dangerous they are. And the other is walking. There's nothing wrong with walking with DVT or PE, and it most likely decreases the chance of propagation of DVT and ultimate PE. Patients can walk if they have blood clots, and I don't care where the clots are. Even if they're free-floating DVT, they can walk. Because for somebody to stand over you and tell you that you've got to have this surgery now, because if not, you're going to die. I know that none of us would imagine saying that to a patient, but that's what the patient heard. And this was a patient that was treated with one of our level 1 PERT team things where somebody came in and said, you've got to have this catheter done. And the patient perceived it as surgery rather than catheter-directed lysis. And then the last one, but they were all in a hurry and they were bringing machines and to hook me up to this and that. And I didn't have a chance to say, please explain what happens to me. I don't understand. Well, we could say that about pretty much every patient in the emergency department. And that last one is just a reminder that, when I approach patients about informed consent and research studies involving pulmonary embolism, and this is not an exaggeration, at least 60% of them are receiving heparin and don't know they have a blood clot. And we think they know what they have, but they can't read our minds. Communicate, it matters. So those are words that don't help, and I just wanted you to see some of those and think about how the patients have these persistent ruminations that lower their quality of life and increase their risk of a PTSD-like phenomenon. So here's my summary. If patients are low risk with PE or DVT, they can go home on monotherapy. That's a new standard of care. If they're normotensive, and meaning they have low risk and their trope is negative, you can just anticoagulate them. If their trope is positive, better not send them home. At least watch and wait. They don't necessarily need lysis. That's another part of the talk that we don't really have a chance to get to. And every patient that's hypotensive, I didn't cover this, but I just want to remind, if patients are hypotensive, they need some type of reperfusion therapy. They don't need to be going home. So to wrap up, here at about 45 minutes, leaving plenty of time to talk and have some discussion, use the PERC rule. It's 1A, it's ready for prime time. Order more D-dimers on all patients, including pregnant patients, and use threshold adjustments for age. use threshold adjustments for pretest probability, meaning those with low pretest prob can have a double D-dimer threshold. Patients that are pregnant and have a low pretest probability can have a double D-dimer threshold. Treat low-risk patients with DVT and PE at home, and consider ordering a lipid panel in all VTE patients that aren't already taking a statin. And tell your patients with PE they're going to be okay. You won't regret saying, we caught you. You are in my care. You are going to be okay. All you have to do is take your medication. And please don't be part of the 8% who never fill their script at 1 month. So that's it for my talk, and I look forward to answering some questions.
Thank you so much, Jeff. I know Megan's been working in the background here, collating some questions. I certainly have some of my own. I think to lead off, probably a lot of people in our collab want to know what you think about our MEDIC consensus-derived algorithm. And I putting you on the spot, and I know you probably haven't really looked at it well. I think it lines up pretty well with what you're laying out in that first slide or two that you were showing, where we walk through a pretest probability of gestalt assessment before branching into PERC versus Wells. And ultimately, I agree with you. I think age-adjusted D-dimer is a important, impactful practice change that we're hoping to achieve across our sites. But any comments about that, just to start?
Sorry, I was just looking at the questions here. The algorithm is great. I don't think that the MEDIC algorithm needs to be improved. It's all about adoption and persistence. And I don't think anybody can make a big difference unless there's measurements. And it looks like you give report cards, you feed back on doctors. I can tell you pretty good evidence that if you just lay it out there and you do a CME course and try to teach people to do stuff and you don't follow up and enforce it and show emails that show how you compare to your colleagues, it's not going to make much of a dent. And I've tried that before, and I've been part of multiple different methods to come in and try to improve quality of CT scanning. And unless there's the compliance component, which I don't know what the right compliance is the right word, the feedback component, and not necessarily public shaming, but showing people how they compare, because doctors and providers are generally competitive and want to do a good job, it won't help. I'm interested in whether you agree with that or not. I don't think it's so much about the perfection of the algorithm as it is the perfection of the feedback.
No, I personally, speaking for myself, being in this business, learning a lot along the way and shepherding our collaborative along with all our partners, I agree. I mean, I think it's about connecting with clinicians in the ways that intrinsically motivate practice change. That this is the right reasons for doing care in the ways it is, that we are following evidence that there is room for improvement. You got to connect sort of to the clinical motivations rather than some external financial incentives. While we have those in place, that's not really about, I think, what motivates people at the end of the day.
Seth Krupp asked, why not just use low-risk wells? And I would say because there's no management studies. I don't know that it gets you to 1.3% chance of PE, and I don't know what the confidence intervals are around that. And I can tell you that in my data sets, it performs almost as good as PERC, but we end up with confidence intervals that are above 2%. I think it's fine. It's just not validated.
Megan, are there other questions coming in? I personally can't see the ones that might be in the Q&A section.
Yep.
Yes. Yep. We have a question from Dr. Brennan from DNC Sinai Grace. Her question is, you mentioned age-adjusted D-dimers several times. In our institution, we argue about how to do this. Does it require a special assay?
No, it depends on which assay you're using, and that threshold can get confusing. For the standard assay, it's 10 times age. If you have the hemocil assay, that's the most common one that uses the D-dimer units, and it has a weird cutoff that can be 238 or 243. I mean, just assume its cutoff is 250 and you use 5 times age for the hemocil. That's the one that uses the D-dimer units. So I hope that answers that question. There was a corollary question to that about using age-adjusted D-dimer. Has it been demonstrated that it has been associated with a decrease in CT use with implementation? And you know, I'm not going to be able to pull the references out right off the top of my head, but there are several that are before and after QA kind of studies that have demonstrated a decrease in CT scan usage and an increase in yield rate. So some evidence of outcome with age adjustment has been shown.
A question from Dr. Benjamin at St. Joseph Mercy Hospital in Ann Arbor. Can you comment on using VQ or even just a Q scan if perfusion is normal and radiation exposure? I consider this with adolescent/young adult women who are PERC positive with positive dimers to avoid chest wall radiation. Radiology suggests radiation is so low in CT these days, this may no longer be a valid alternative.
I mentioned it in pregnant patients, and a Q scan with a normal chest X-ray is going to have fairly high specificity, above 75%. It's not going to have the specificity of a CT scan. And, you know, with dose modulation, a CT scan, yeah, I know that they are decreasing their, you know, millisievert radiation dose. I have to defer to them and their phantom studies and what exact protocol they're doing. I do want to say one thing is when you're doing dose modulation of CT scan, without a doubt, you lose you lose quality. It's pretty funny. I'm just going to make a tongue-in-cheek comment here. About 20 years ago, when we first started using single head detector scans, you could basically see down to about the segmental pulmonary arteries, and you could not see subsegmentals. And then with the multi-detector row head scans, we could see the subsegmental PEs, subsegmental arteries. And with more radiation than a single head. But that led to the whole subsegmental debacle of whether you see a single subsegmental defect with no DVT, does that patient need to be treated? Raised lots of concern. And then now the engineers and radiologists are coming with dose modulation CT scan using the multi-detector scan. And basically they've made the imaging look exactly the same as it did 20 years ago. You can't see the subsegmental arteries. There's lower radiation. So it's we sort of took this technology and kind of made it worse so that it looks like what it did 20 years ago and gives about the same information. So I don't know what to say about that, but I do think that that the lower dose modulation is the way to go because it solves two problems, and that is breast radiation and also the subsegmental PE problem.
Any other questions? Yeah, Megan, another question?
Yeah, one more here from Dr. Plemons from Henry Ford Wyandotte. She notes that she developed their outpatient DVT protocol, and it would be very easy to move into PE outpatient treatment, but she's curious about getting their medical staff to support this. Do you have any ideas on how to get their support?
Yeah, they need clinical practice guideline endorsement. So the first thing is to just point to what ACCP said and what ESC said. And you know what else they want? They want literature. And, you know, I've shown you an implementation trial that we've done that is not published. It's, you know, this is the invite a researcher. I want to tell you about my research. It's not out there yet, but I think that will help. There are other large studies that are out. The home PE trial that Pierre Marie is doing that I referenced is in review. And then there is the HOT-PE, H-O-T-P-E study by Stavros Konstantinidis that was published in the European Respiratory Journal. And so more and more evidence is coming down. I think they want to see this safety and they want to know that, like, this is what I'm supposed to be doing. I guess ultimately when someone comes along and says, we're not paying for this admission, then that will really clinch it, but we're not there yet. So I think that you can be ahead of the curve by telling your staff and your colleagues that this is a best practice, there's new evidence happening, and it has clinical practice guideline endorsement, and will continue to have more and more endorsement.
I'd add, I mean, I think it's something that we may consider adopting as one of our quality initiatives in the future. I mean, we certainly, in the next couple of years, will want to bring online some additional areas of care, and certainly one of our areas is around the hospitalization decision, and certainly PE, I think, is one of those conditions that could be a target.
Yeah, and may I say, I would be interested to see how many DVTs you're sending home. And again, there's a big gap between what people think they're doing and what they're actually doing with DVT. And I showed 3 citations which all show that fewer than 25% of eligible DVT patients are actually sent home. Now, it doesn't get to why. They could have social reasons, I don't know, but the percentage that are going home with DVT are not as high as a lot of people think.
Yeah, it's a great point, and certainly broadening it to VTE makes a lot of sense, particularly because like PE numbers tend to be smaller, just volume-wise than DVT. So there's more opportunity for improvement there.
It's 2 to 1. 2 to 1.
I do have another question. I don't know, Megan, if we've got more from the audience. Okay, you gave me the thumbs up. I'm curious, Jeff, as you sort of see into the future, you know, we're in the implementation side, the quality improvement side. I mean, are we done with like deriving clinical decision rules for PE? I mean, we seem to have new ones every year almost. You know, what may be next? I mean, machine learning, artificial intelligence as a way to sort of make the, you know, Gestalt CT decision. What do you think?
Yeah, I think we really solved the problem of pretest prob and the dimer, and the CT is a good test overall. This is a much different problem than it was 20 years ago. And, you know, part of the whole reason that COVID looks like it's so thrombogenic is we screen way more than we did with H1N1 influenza, which was also thrombogenic. You know, we kind of have this problem under control, and I think, you know, sort of fine tuning the threshold is really important. Now let me try to address your question as a person whose life is immersed in this in lots of ways, including that as an expert witness in medical malpractice cases. And there are still hundreds of people dying every year from pulmonary embolism that should be alive today. It is not as many as it used to be, but the reason they die is the doctor or advanced care practitioner doesn't think about PE appropriately, meaning out of the Gestalt. Who is it that rises to the threshold of starting the PERC rule or starting Wells criteria or starting even Gestalt? Once you start thinking about PE, the patient is safe. I always teach my residents this. You are not going to kill somebody once you start thinking about PE. It's when you don't think about it. So that, to me, Keith, is where the real research is. It could be machine learning. I've done a lot with machine learning over the years. I think it's advancing, and there could be flags that, you know, you need to be reminded of. You know, usually in med mal cases, there is a signal there that is a hard signal. Sometimes it's not, but this knowing when to begin to start thinking is that's where the life and death decision is. How do you teach Gestalt, or how do you supervise it, perhaps with something running out of an electronic medical record? I don't have the answer right now. I think it's lectures like this, it's training, it's the skill and thought processes of the people on this meeting now, teaching others to think about PE. But don't be scared. Don't order a test just because you thought about it. Mm-hmm. Use your mind.
That's great. Well, let me give one more opportunity for any other questions. We do have another question.
I see a couple.
Okay.
Jeff Kline, this is Michelle Nypaver. I'm the co-director of MEDIC. You let us know that you were starting to think about working with PCARN, and I don't know, without revealing too much, if you can give us a little bit of some insight. I live in the land of young adult women on oral contraceptives who frequently are complaining of chest pain and the pediatrician in me says, don't do any CT scans. On the other hand, which ones deserve these? It's a very important question for us.
Right, right. And, this is probably why this, I put a lot of applications into the NIH, and I get a lot of not funded applications, and this one got funded, I think, because the panels recognized the significance of this problem. We have nothing to go on in young adults, meaning those, that are teenage. There's not a single prospective study done on the diagnosis of VTE at all. So this study is called BEEPR, Bedside Exclusion of Pulmonary Embolism Without the Use of Ionizing Radiation in Children. And again, we're using a modified version of the PERC rule. And it's not a management study. It is enrolling all patients that have D-dimer or CT scan or a test that was canceled. And we are looking at their 45-day outcome. So this will be done through the 18 PCARN sites plus Indiana Raleigh Hospital. So not ready for prime time. Everything is retrospective at this point. Even the D-dimer is not well known in children, with highly disparate findings ranging with sensitivities between 79 and 100%. I wish I had a better answer, but it's the need for the study.
Can I ask, what's the age that you're studying this rule in? I'm just curious.
Yeah, under 18.
And is there like a lower bound to that age, I assume, like,
Yeah.
12 and above or something, or?
Yeah, above 3, so 4 to.
Okay, yeah, that low, okay, yeah.
Yeah, we do think infants are different in that they have different reasons. The infants get clots, but they're usually in the NICU, so it's not something that we think we're ready to put in. There's a question I'd like to. I hope that answers that question about children and young adults. And thanks for letting me talk about it. It's 11:01, but there's a question I wanted to address. It's from Angela Medrano, and it's other than words of encouragement, are the suggestions to prevent providers from causing the discussed mental health impacts. And no, at this point, peer support, referring patients for counseling, we don't know any signal of efficacy for that because it's not been tested. I'm just going to hold out that it's self-evident that there's nothing wrong with words of reassurance. Reassurance is some of the most powerful medicine that is understudied. It is stronger than placebo effect, and patients with clots need to know that they're going to be okay if they take their medicine. Their probability of survival, even with severe PE, is 95%. There's nothing wrong. No one is going to come back and tell you you're bad. If you tell patients that have clots, you're going to be okay now. I got this. I caught it. This could have been serious if we didn't catch it, but it is easily treated with this medication that will prevent future clots. Oh, and by the way, please don't use the word blood thinner. I hate that word. That word makes patients nervous. It's not thinning the blood. It is preventing clots. Please call it clot-preventing medicine or medicine that stops clots, or even use the word anticoagulant. But blood thinner is another thing that patients think means that they don't have enough red blood cells and that their blood is going to come out of their ears, or if they cut themselves, they're going to bleed to death.
We have several more questions. I know we have just a few more minutes here. Dr.
Yeah, I mean,
Kline.
we have certainly another 10 minutes, so let's keep going. Yeah.
So this question comes from Dr. Dennis at Beaumont Troy. Considering MEDIC performance goals, including value-focused evaluation for PE, are based on data established using participating site data prior to the advent of COVID, how do you see COVID affecting the likely yield of CTA for PE studies? Do you feel it is likely there will be more studies ordered due to concern COVID is a thrombogenic disease? And might there be a lower yield due to greater numbers of studies, or might the yield increase due to greater prevalence?
Thanks for the question, Dennis. And I anticipated this. In fact, I have a talk called Clots and COVID. And, we spend a lot of time addressing this. And I'm going to give a little bit of a contrarian statement, and that statement is that I don't think that SARS-CoV-2 is much different than any other severe viral infection in terms of its thrombogenicity. It got a lot of press early on. It is possible this virus has mutated and it is less thrombogenic now than it was when it was moving across China and into the Netherlands. There's two papers coming out. One is, again, by Jonathan Freund. Jonathan did that proper study for PERC that I'm talking about, where he has shown in propensity matched samples that the prevalence of PE on CTPA scan was 15% in multiple institutions around Paris prior to COVID and 15% afterward. There is another large study that is being published in the European Heart Journal, again from a French group, not Jonathan, that is a large multi-center study that shows the prevalence of PE and CTPA being done in France is 8%. So those numbers are lower than what we saw pre-scan. So I think your sense that the threshold has lowered, that more people ordered CT scans than would have, is true. I can tell you that in our registry, I didn't present these data, but I have a thing called the Recover Registry, which is 43 investigators representing 150 hospitals across the United States. We now have 17,000 entries. And what we're looking at are patients that present to the emergency department with symptoms and are tested, have an RT-PCR swab done for COVID. So we have 1/3 that are positive and 2/3 that are negative, allowing some case control comparison. The prevalence of VTE in the patients who are COVID negative, 1.7%. The prevalence of VTE, and this is with 30-day outcomes, of patients that are SARS-CoV-2 positive is 2.7%, 2.7 versus 1.7, so a relative risk or risk ratio a little over 1.5. Not super powerful, not super impressive. But yes, it is no doubt that it has modulated the threshold of D-dimer and CT scan ordering. And I know about all the concerns of the CT scan magically being contaminated by patients with COVID, but there's still a lot of CTs being done.
Yeah, and I'll add, we have yet to really dig into our own registry data. We have some data catch up to do because many of our abstractors were tasked to other areas and hospitals during the pandemic. But it'll be interesting to see what our own registry data looks like. I think it's mixed. I think we see some increases in diagnostic yield, some drops in diagnostic yield. I think it's complicated for exactly what you said, Jeff, because some people may have been less likely to use the scanner just because of the problems of decontamination afterwards too. And we're just treating empirically, and those would not necessarily be things that we would pick up in the ED per se. Any other questions,
Yep.
Megan? Yeah, okay.
Another question here from Chris Port. What is your opinion on mechanical thrombectomy? What criteria should be utilized on when to consider it for DVT?
Okay, the question is focused on DVT, and allow me to offer that I believe you're going to see a lot more suction catheter use for patients with pulmonary embolism. There's one in particular by Inari called the FlowTriever. There are others, and these devices work as well and faster and safer than catheter-directed lysis. I believe you will see suction catheters if you're IR folks, and this is almost always an IR, not an interventional cardiology procedure, become skilled and facile with using it. It's a great device, and it definitely lowers PAPs, and it lowers them fast and better and safer than catheter-directed lysis. Now that's PE. DVT, mechanical thrombectomy, usually this is pharmacomechanical, and the one trial we have is the ATTRACT trial, which was the paper of the year in the New England Journal in 2018, and basically found no difference in the development of thrombophlebitis for those that were randomized to receive catheter-directed treatment for DVT versus those that didn't. In a subset analysis, those that had high and tight clots, and I call high and tight clots, those are up in the common femoral artery above the takeoff of the saphenous or at the takeoff of the saphenous, those patients did benefit. So there's still this question of, if you like it, you can make the data say it is good for the really high up clots. What would I want for my family member? If I saw a high and tight clot, one above the saphenous vein, and the patient and my family member had a swollen, painful leg, I would want it for that family member, because those are the ones, the subset of the ATTRACT trial that were likely to benefit for DVT.
Thank you. Another question here from Dr. Dennis at Beaumont Troy. Knowing that prior to the availability of high-resolution helical CT for PE, autopsy data indicated it was not uncommon for individuals to have experienced pulmonary emboli, which were undetected and likely of no clinical significance. Do you feel all PE, including subsegmental, represents disease concerning enough to warrant treatment and requires study for detection? Or is it acceptable to acknowledge there may be some small pulmonary emboli we do not need to detect, as they would not warrant treatment and therefore do not need to investigate to find?
All right. Well, thank you for that question. Again, it's a good one. And I don't know if folks can see my face, but I'm taking my glasses on and off because I'm old and I need them to see, but they have a glare, so I'm trying to take them off because it's kind of weird to look at somebody with glare in the glasses. So yeah, I'm going to give you my summary that I know over doing this for 20 years, and that is that the job of the lungs is to catch clots, and to the best that we can make inferences doing scans on asymptomatic patients that had scans done for staging of different diseases, including cancer, which is a risk for clots, that you can find about 1 to 1.5% of people walking around on the street that are over age 40 with a filling defect consistent with acute PE and no symptoms whatsoever. Like there's anecdotal things that say you catch a lot of clots in your lungs and never know it. Surely someone in this 106 participants has had the experience where you have done a bedside ultrasound of the common femoral vein and seen a big clot there, and there's a clear-cut compression defect. You can see that white clot in there, and you record it, and then you bring a learner over and say, hey, I want to show you this DVT, and you go to the same vein and it's gone. The clot is gone. Now, where did it go? You look up at the patient and you expect the pulse ox to be 0 and the patient to be in distress. They don't feel a thing. They feel nothing. And I mean, I know where that clot is, but it gave them no symptoms. Yes, there are many asymptomatic clots, and the subsegmental PE problem, I think the radiologists helped us solve the problem by doing the dose modulation and making it so they don't really see the subsegmentals as well as they used to. And I also think that they've done a good job of kind of quietly stopping the call of all those single isolated subsegmental defects. I see that problem as waning rather than waxing, the subsegmental problem. I think kind of everybody sort of implicitly got on board that these people don't need to be treated. We published a systematic review looking at what was available, looking at the treatment versus not treatment of subsegmental, and in general, things were worse with treatment.
Thank you. The final question that we have on here is from, sorry, go ahead, Keith.
Yeah, I was going to say, let's do one more question.
Yep.
So,
from
yeah.
Dr. Krupp at Henry Ford, Detroit. When are insurance companies going to make it simple for us to just prescribe DOACs, D-O-A-C-S? This is a limiting factor that causes observation/admission to be fallback, often due to headache of dealing with logistics of pre-authorization, free prescriptions, et cetera.
Yeah, I think when the Medic Collaborative shows them that it'll save them money.
Yeah. All right, I'm getting a thumbs up, and we are definitely right at time, which is awesome. So thank you so much, Jeff, for your wisdom. You can tell by the questions, so many people were taken by the subject, and is such a, at the heart of what we're doing here. So thank you so much for your time. Really appreciate connecting with you, and we'll hopefully run into each other in the future.